Hey, it's good to see so many faces after seeing that title. I'm assuming that everyone is here for a riveting tale of costing. So, here are my disclosures. So, jumping right into it, let's look at some background. So, why is costing important? Well, for anyone that's performing an economic evaluation, as we've seen today, of course, the cost of managing hepatitis C is very important. Now, the cost of hepatitis C is very variable. Right? You could have an individual who has no fibrosis and otherwise looks perfectly healthy, or you could have an individual who has decompensated cirrhosis and is awaiting a liver transplant. So the cost of those two states is going to be very different. So identifying what states individuals fall into and what the cost of that associated state is very important to obtain accurate estimates for our economic models. So currently in the literature, we do have Canadian cost-based estimates, but these are time-based. So we know what the cost of the early phase of disease is, the late phase of disease, and the terminal phase. The problem is that the definitions of these phases is very broad. So if you take the late phase, for example, that includes everyone who has advanced liver disease. So that includes individuals with compensated cirrhosis, decompensated cirrhosis, those with liver cancer, those who are receiving a liver transplant. And of course, the cost of each one of those items that I just talked about is going to be very different. So our objective was to obtain much more granular level of detail, which could used in economic models to produce more accurate results. So to do this, we had to identify a cohort of individuals who had hepatitis C. So to do that, we used the Public Health Ontario lab data, which holds all the information on individuals who receive RNA or HCV antibody test. And we looked from 2003 to 2014. And then we applied the following exclusion criteria. So we only wanted to look at chronic cases of hepatitis C. So we excluded those who had an acute infection or those who had a past infection that was previously cured, so that antibody would be positive, but the RNA would be negative. We're only looking at monoinfection, so we excluded individuals who had hepatitis B, a co-infection of hepatitis B or HIV. And finally, we're only looking at adults with OHIP coverage. Now, for those of you that don't know, OHIP is the Ontario Health Insurance Plan, and if you're not covered by OHIP, we can't track your costs, so we had to exclude these patients for logistical reasons. And by only looking at adults, we're excluding individuals under the age of 18. So these are the 9 health states that we wanted to find the cost for. So we wanted to find out what is the cost per 30 days of being in one of these health states. So you'll notice there are 2 health states there that are for individuals with no liver disease. Then we have 5 health states for individuals with advanced liver disease. And then we have 2 states for individuals in the terminal phase. Now we classed terminal as the last 6 months of life, and we separated this out to individuals who die with advanced liver disease and those who die without advanced liver disease. Now, if you look back through a patient's history using administrative data, you can identify points in time when they enter these health states based on diagnostic procedure ICD-9 and 10 codes. And there was a recent study by Lauren LaPointe-Shaw and her team who identified what the definitions of each one of compensated cirrhosis, decompensated cirrhosis, and HCC is. So how you can identify these patients using the administrative data. So this was the methodology we applied. So we have identified the cohort. The first step is we're going to allocate you into one of those 9 mutually exclusive health states. So when I say mutually exclusive, you can't be in 2 of those health states at any given point in time. Then what we did is we looked at the individual's history and we followed them up from the time of diagnosis right up until the end of follow-up. And end of follow-up could be either death, loss of OHIP coverage, or December 30th, 2016. That was as far as we could look back from. And then during that period of follow-up, obviously the individual can move between these health states. So you could have an individual who has no cirrhosis, and then after 5 years, they may develop compensated cirrhosis, in which point they leave the no cirrhosis state and they enter the compensated cirrhosis state. And then the final stage is costing based on the resource utilization that was incurred during the time you spent in each state. So hopefully this will make things a little bit clearer. So this is just an example. So we've identified an individual who's diagnosed with hepatitis C, and we look through all of their administrative codes, and we note that this individual does not have cirrhosis. We follow them up over a period of time, and we noticed that at this point in the patient's history, they developed the correct algorithm, the correct diagnostic codes to say that they have developed cirrhosis. We keep following up, and we note at this point they develop decompensated cirrhosis based on the administrative codes. And then we reach December 30th, 2016, we can't follow them up anymore. So now we've done that and we've categorized their time, how much time they spent in each state. We look at the resource utilization. So we say, okay, what was your resource utilization during that period? We're going to cost that out, and we're going to attribute those costs to the no cirrhosis state. We're going to attribute any resource utilization during this period of time and attribute those costs to compensated cirrhosis. And then, because nothing else happens to this patient, the remainder of the time is going to be attributed to the decompensated cirrhosis state. So this is just an example of some of the databases we access. This is not an exhaustive list. This is just to give you a flavor of some of the where some of the data came from. So moving straight on to the results. So we identified 65,000 individuals from 2003 to 2014 who had a positive RNA or positive antibody test result. We then applied our exclusion criteria. So remember, we're only looking at monochronic adult infections, and we're left with a cohort size of 48,000, which is more than enough to obtain some statistically significant results. So the first step is allocating them to a health state. So what this pie chart represents is the allocation of health state at the time of diagnosis. So you'll notice that 90% of individuals at the time of their HCV diagnosis did not have cirrhosis. 5% did have compensated cirrhosis at the time of their HCV diagnosis. So you would probably think, that's a shame, that's a late diagnosis. We could have perhaps prevented that if we had caught that earlier. And then likewise, the remaining 5% either fell in between decompensated cirrhosis, HCC, and we also had 1.4% of the population who died within 6 months of their HCV diagnosis. Now, like I said, you can move between states over time. We don't just put you in a health state and then attach all of your costs for the remainder of your life to that health state. So if you look at this bar graph is the word, technical term. The blue bar represents the number of individuals who enter that state after diagnosis, and the green bar represents the number of patients that enter that state at diagnosis. So if you take the bottom bar, for example, no compensated cirrhosis, RNA negative, these are individuals who effectively have their HCV cured. You'll notice there's no green bar. Of course, you can't be cured on the day of diagnosis. I don't think treatment has got that good just yet. And you'll notice that we identified 6,000 individuals in our cohort who became RNA negative over time. Now, if you look at the advanced liver disease states, such as HCC and DC, the majority of cases that we were looking at were individuals who entered that state after diagnosis. So we're looking at individuals who have been diagnosed with hepatitis C, and then as time's gone on, they've developed decompensated cirrhosis or hepatocellular carcinoma. So moving on to the results. So the current Canadian estimates are phase-based. So what I've done is to try and make our results more translatable, I've attached each state to the most applicable phase. So early phase is individuals with no late-stage liver disease. And we have 2 states which represent these individuals. So we have individuals with no cirrhosis and individuals with no cirrhosis who obtain an RNA negative result. So the first thing to note is our costs are a lot higher. They're about double, nearly triple. And what you also find is that the cost of having your HCV cured is lower. So individuals who obtain an RNA negative result have lower costs to the health service than those who maintain their HCV diagnosis, even though they don't have advanced liver disease. Now, if we move on to the advanced liver disease states, you'll notice that our costs are much higher now. If you have compensated cirrhosis, we're saying it costs $1,500 to the health service per 30 days, effectively per month. And if you're in the late phase, currently we're saying that if you're in the late phase, it costs $900. But then if you look at someone who has hepatocellular carcinoma and decompensated cirrhosis, we're saying it costs $8,700 per month. Whereas if you was building an economic model right now, the cost value that you would be using would be the $904 per month. So two things to note. One is our costs are higher, but also look at that variability. Our costs range from 1,400 for an individual with compensated cirrhosis all the way up to 8,000 for an individual with decompensated cirrhosis and HCC. So it's not just that our costs are a lot higher, but we have this massive variability, which shows how important it is to use state-based cost estimates for economic models. So there are maybe a couple of reasons why our costs are a lot higher. A couple of theories. So first of all, you'll note that our costs are 2018 Canadian dollars. The current cost estimates are 2005 Canadian dollars. So inflate that, and you're going to close the gap a little bit. Likewise, our cohort was a lot more modern. Right? So we were looking from 2003 to 2014, whereas the current estimates come from 1997 to 2004. So changes in healthcare and the way that treatment's managed may explain why the costs are more expensive. What we do find is that our costs are more in line with international estimates. There aren't many state-based costing studies that are out there. There's one that was done in the US, and our costs are actually lower, which kind of makes sense because US costs tend to be higher, but it shows that our figures are within the right ballpark. So conclusions, so there's two main conclusions to take from this. So first of all, our costs provide a more granular estimation of hepatitis C, and based on that variability, you can see why that's an important thing to note when you're building economic evaluations. And secondly, our costs are a lot higher. So if we use the current cost estimates for our models to predict, what are the cost savings down the line from preventing decompensated cirrhosis and HCC. If we use the current estimates, we're going to be massively underestimating those potential cost savings. And with that, I'm bang on time. Thank you very much. And these are the corresponding authors who helped build this topic. Thank you.
Thank you, Alex. We have time for one pressing question, if there is any.
Hi, very nice talk. My question's not pressing, but I'll ask it nevertheless. Did you model in the natural history for the length of time that those costs would be borne by the patients in each of those disease states going forward until death, such that you looked at the finite number of years that a person with decompensated liver disease would be expected to live with or without a transplant setting versus the amortized cost, albeit fractionally much smaller in the cured patient of $1,000 per month over the rest of that person's life?
So we looked at, we identified patients from 2003 to 2014. Now, obviously, the patients we identified in 2003, we had a full, rich history to look at. So these individuals are going to be moving between states. But obviously, for individuals who we identify in 2014, we had a much shorter window of time to look at their transitions between health states. I'm going to break the cardinal sin and say I don't think I answered your question there. But we did look at differences. The difficulty is we couldn't say, let's look at the average amount of time an individual spent in a health state, because we had individuals who we were looking at for 12 years and individuals who we were only looking at for 1 year. So when you average out that number, it's not going to be clinically relevant.
Right. I guess one way to overcome that would be to use natural history estimates of how long disease states last, maybe historically, prior to eradication therapy. You couldn't probably do it in a short period of time in the 5-year cohort for your data, but you may be able to infuse or impute cost estimates from extrapolated from historical control data.
Absolutely, and this is still an ongoing project, and there's other data that I haven't presented here. We also have done regression models for each one of these health states to find out what the predictors of costs were, whether it be immigration or age or comorbidities. So it's an evolving data set that we can still play around with. This is just the kind of preliminary estimates that we just wanted to get out there while the topic of hepatitis C is still fresh.
Thank you. Very nice work. Thank you.